I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's? The current fee-for-service healthcare system rations out care based on the patient's ability to pay. I believe this is unethical. It is criminal. 95% of the country is still functioning on this fee-for-service model. I believe everyone should be treated the same. Everyone should have access to primary care regardless of their ability to pay. Hi, I'm Dr. Faisel Syed. Welcome to another episode of Faisel and Friends. We're here because we believe everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Exciting things are happening at Faisel and Friends this year. Starting in February, we will no longer be going live on social media. But don't worry, you can find us wherever you listen to podcasts. Episodes will be available every Thursday. Tonight's topic is renal disease management in primary care. My co-host and moderator of the chat is Dr. Dan McCarter. Welcome, Dr. Dan.
Hey, Faisel. It's great to be with you again this evening.
It's great to be back again. We're back again live. How are you doing tonight?
I'm doing well.
I've really been enjoying this specialty series we've been doing, and tonight in particular, I'm really excited about having ChenMed's National Director of Nephrology joining us, Dr. Kheda. Dr. Kheda, welcome.
Hello, Faisal. Hey, Dr. Dan, how are you? Thank you for having me.
This is great. I mean, I feel so happy with the direction the company has been moving over the last couple of years. Now we've got access to so many specialists, and not even with the traditional consult where you have to put in a formal consult to reach out to your nephrologist for a nephrology question, but actually being able to text or even make a phone call, just a quick curbside. I mean, this is just an exciting time right now. I really feel like we're redefining the relationship between the doctors and patients, doctors and doctors, as well as the way doctors work with our staff. So thank you so much for joining us tonight.
My pleasure.
Dr. Kheda, would love to hear your story about where you went to school, where you trained, and how did you end up coming to ChenMed?
So I'll pack it in as short as I can. So I immigrated from India about 20 years ago, and I was in South Carolina when I started my journey in United States. And the job I could find after months of searching was to be a dialysis technician in a rural clinic in a dialysis clinic in rural Georgia, which is a dialysis tech. It's kind of like a patient care tech. You're assisting the nurse with daily chores. The beauty of that job that I did for a year is the reason I am a nephrologist today.
Wow.
The experiences I had with the patient, being with them 12 hours a week, because they come for dialysis 3 days a week for 4 hours. So 12 hours of the experience, that the continuity of kind of care as well as relating and personally engaging, and I kind of enjoyed it. Elderly population, continuity of care, stories they would share. I just like, can I do this for full time? And they say, yeah, you can become a nephrologist and do this. And went to residency, and the day one of residency, I said, I want to be a nephrologist, and here I am.
Wow.
There are very few nephrologists, Faisal, in United States who started their journey that way. But I'm privileged to be there because I may be the few of them, if any, who can even string a dialysis machine. So if I used to get a call from the ER that a patient is crashing and they need urgent dialysis, I could show up and start the patient on dialysis even before my nurse comes in.
Wow. It's an incredible story. You came from India and you started your journey as a tech, and then going and applying for residency and deciding so early on.
Yes, it was. And Medical College of Georgia in Augusta, Georgia has been my home for my residency and fellowship training. And thereafter, I kind of practiced in South Georgia, just, private practice experience for 12 years until I kind of fell in love with the value-based care. It took off in a kidney space in a small way. So I was doing it as a part-time thing, gaining skills for the last 5 to 7 years, participating in CMMI programs related to value-based care. And when ChenMed opportunity came along, it was no brainer for me. I was like, oh my gosh, I can do this 100% of the time, and impact kidney care on such a large scale as big as ChenMed is. It's just beautiful. I mean, it was a no brainer, and here I am enjoying it, loving it.
Wow. Yeah, because I mean, what you were doing in Georgia, and now the ability to be able to have an impact and connect with doctors in 12 states, at least up till now, and hopefully this year another 3 or 4 more will be in 15 or 16 states this year. So it's a really powerful ability to impact practicing primary care doctors and their patients. So, what are your interactions like with the doctors?
Oh, well, let's do an example. So Friday, I got a call from our primary care doctor in Jacksonville. Right, this is an example that really opens a Pandora's box. What's broken with the kidney care nowadays? Um, our primary care physician calls me on Friday. Hey, Dr. Kheda, I tried to send a patient to a nephrologist, and they're telling me send this patient now to the ER. I don't need to see him in the office. He needs to go to the hospital. I was like, okay, let's look at it. So I discussed with him the case. I looked at the labs and all that stuff. Everything can be managed outpatient on this guy. He is unfortunately closing in to starting dialysis. I mean, this is one of those issues. What we reflect is inadequate preparation for dialysis issue.
Mm.
So he just never got all the ducks in the row to prepare and educate and plan for dialysis, and here he's needing to start dialysis, but he didn't need to start dialysis in the hospital. So I worked with the PCP on Friday, then we caught up today, Monday we caught up day before and did labs. I looked at the labs. We planned a visit with a nephrologist in Jacksonville, and I'm kind of assisting the PCP in delivering the right nephrology care. And here, this patient is going to probably start dialysis later this week in the outpatient setting in Jacksonville. PCP is happy, patient is happy. I think that's.
So I've got to ask the question because in my prior life, I was attempting to run an ACO, and so for the life, I mean, tell me why in a country with what people would like to argue is some of the best healthcare, and I would say it probably is some of the best episodic healthcare in the world. Why do we have so many people crashing into dialysis? Why, why did that nephrologist tell our PCP to send the patient to the emergency room in the middle of a pandemic, no less, when the patient could have been exposed to COVID, and even if fully immunized, a patient who's heading towards dialysis would be at pretty high risk. I think what you did is phenomenal, but why aren't all the nephrologists doing this? There's got to be a reason.
Yeah, Dr. Dan, there is this problem actually takes root in the lack of innovation that's in kidney space. That is, we do not believe in the nephrology community that patients have ability to understand their disease state, converse about the disease, and participate in care, and they will do the right action to make, there's this mindset among nephrologists and the community that it's too difficult to educate a patient, prepare for dialysis, and it's become like, why waste energy behind something that we would not win the battle? And thereafter it's become somewhat of a tradition for the past decade or some over the decade that somebody needs to start dialysis, just send them to the hospital, and they will be what we call crash into dialysis. It's unfortunate that a country as advanced as we are, an 80% crash rate, 80% of the dialysis in this country is starting in this crash format.
But I guess it's safer if you go into the hospital and somebody puts a central line in, right?
It sure is.
I'm just kidding, right? I mean,
it is a good thing when it's needed, but I tell you, we can avoid this 99% of the time. Yeah.
But I mean, there's a big. I mean, you still get line infections with those.
You do.
When you crash into dialysis, you get line infections. You get the risk of blood clots coming off the lines. Whereas if you
Hmm.
have the ability to put the access in and allow it to heal and be ready to use, isn't it much safer to do
It
that?
sure is. Having a arm access is anytime better than a dialysis catheter. The mortality in the first 3 to 4 months of starting dialysis is almost 50% less. So there's almost double survival with patient who has arm access than not have arm access. Dr. Dan, I'm going to add one more thing to it. Why are we failing so much is also, about 30 to 35% of the patients that starts dialysis have not seen a nephrologist ever. Now we can ask ourselves, so is it the fault of the nephrologist whom they've never seen? Or is it the fault of our system, healthcare system, that are we referring patients too late? Are we not talking about kidney disease with our patient? We got to ask ourselves in a broader sense.
Right. I mean, I think, as in a lot of things in life, timing is pretty key, getting the referral at the right point in time, but then having the collaboration like you did with the PCP, right?
Yep.
The PCP didn't turn the patient over to you.
Nope.
Uh, they had the relationship. They were working with the patient to get them to do what they needed to do. They needed the help from you to be able to make the plans efficiently to make sure the patient was getting what they needed as efficiently as possible.
In primary care, what you don't know, you don't know. Right? I mean, in any business's life, what you don't know, you don't know. And the beauty that's happening at ChenMed is every PCP now has the ability to manage a advanced kidney disease. I mean, Faisal, tell me how many times you run into our PCPs in our centers and they understand what crash into dialysis means. Just about everybody across the country in our company, what late stage CKD means. It's beautiful that we have that kind of resources and trained our PCP to think those way.
Yeah, the system doesn't think of it that way. Like you said, the culture has now accepted that, hey, like what happened with the nephrologist and the primary care doctor in Jacksonville, just send the patient to the emergency room or send the patient to the hospital. Do you think that if the nephrologist knew that, hey, the resources that this patient had, being a patient of ChenMed, that the nephrologist would perhaps have been a little bit less inclined to make that recommendation? Or do you just think it's just gotten to the point now where patient just needs to go to the hospital?
Great question. Whenever I get a situation like this, and when me or my team, my kidney care team, picks up the phone and calls a nephrologist and say, "Hey, this is our patient." Once they know it's a ChenMed patient, or they know we have a team, we have all the resources to drive the 18-step process. So we have defined a process at ChenMed that the moment a PCP says my patient is in danger, we hold hands and we make it happen that patient starts dialysis safely in the outpatient setting. And we have whenever we communicate this, that we have a process in place, nephrologist, they are on board, they always support, and then there was never a fight, no contest on this. Like, yeah, please do that, and let me know how I can help.
For the people who don't have access to this type of a relationship, in many ways, I can't really blame the nephrologist for having sending the patients to the hospital. I mean, what other option do they have? I mean, to just trust and rely on the patients in a system where it's just kind of, do whatever you can. It's survival of whoever has access. Everyone else, it's good luck.
You're absolutely right. Preparing for dialysis is a very tedious, time-consuming it's not just, first you got to educate them about kidney failure. Then you got to tell them about the choices of treatment they have, which are about 4 different types of dialysis, plus palliative care, plus kidney. So it's like 6 different choices you got to educate them on. And then it's like it takes almost 3 to 4 hours of session time with the patient to get them through educated and have them on board with it. And it, if there's no time to do it, there's no time to do it. But then the opportunity is with the primary care. Who sees the patient most? Us. The patient trusts us the most. We have that bond, the relationship with the patient. So if we start early upstream at our level in primary care, um, it leads to better outcomes.
I agree with you. And I remember when I first joined as a primary care doctor, one of the one of the shocking situations I was coming into with our patients, especially the diabetics and the hypertensive patients, was these patients with the stage 1, stage 2 kidney disease, and they had no idea for years. And then once we mentioned it to them, me and our care team started mentioning to them, hey, your GFR is in the 70s. We were talking about making some healthier lifestyle choices, maybe switching from eating regular rice to rice cauliflower. The patients we used these or the earlier stages of kidney disease to help influence the patients to make better lifestyle choices.
There's such an opportunity ahead of us, even now and in the next 10 years, to decrease the dialysis incidence rate. Couple of years in 2019, there was an executive order from White House, an executive order naming American Advancing American Kidney Health Initiative, an executive order from the White House saying we can decrease incidence of dialysis by 25% by managing primary care items better, managing diabetes better, hypertension better, and investing in medications and therapies that we know prevents progression of kidney disease. So I'm glad, Faisal, you're sharing that. I think we can have a bigger impact if we early diagnose kidney disease early by measuring proteinuria and GFR, and then intervening in timely fashion so our patients don't have to go through the journey of late stage kidney disease and ESRD.
So, Dr. Kheda, we have a comment from Dr. Shaw, and he says that only 5% of nephrology practices are actually providing education. And I just wonder what your thoughts are about that. And if you agree, what do you think is driving that number?
What a shame, right? I mean, how many times, Dr. Dan, we have patients in common. We send to a nephrologist for dialysis education. The patient comes back to us. How was the visit? Oh, he said everything was okay. I'm like, okay. I mean, what about dialysis education? Oh, I don't know. We didn't talk about it. That is a norm. I think part of the problem lies with the reimbursement model because many nephrologists are still in the fee-for-service world. The reimbursement model that is currently in play is not sufficient. It's not aligned with running a private practice. And then the nephrologists are then relying on other agencies like a dialysis provider to provide kidney disease education. So it's a sad situation that there's no time to educate patient, and that burden downstream you see in patient on dialysis then. Yeah.
Right. And I know that people who work in dialysis centers, they want the best for their patients, but isn't getting a dialysis center to do education about transplant sort of like getting asking Cadillac to give you education about Teslas or something on that order?
Yeah, I mean, there was a study not too long ago where they compared the dialysis providers in the country, and some of the major dialysis providers who we like to call them for-profit LDO, that's just a jargon we use in nephrology, showed that transplant referral rate was lower in those patient population. And then there was a kind of an argument to be made that it's not happening enough. There are about, in any given time, there's only 3 to 5% patient in any dialysis clinic who are listed for dialysis, for transplant, sorry. So such a low referral rate and listing rate. And the sadness I'm going to go expand and say is the disparity across the country. We have a situation in Midwest where you get patients who got like 30-40% refer for transplant, and then you have other states, Texas and South, low transplant referral rate. There's such a disparity that there's something is wrong in the way we practice and the access we provide to our patients regarding transplant as well as home dialysis. We are filling the gap though, Dr. Dan. At ChenMed, we have a very strong team. So what we said to ourselves when I came on board, we designed this program at ChenMed Kidney Care, and we said, we're going to do it for the patient. We, PCP-led care team, will do it for the patient with support of this kidney team. I'm the only nephrologist. People ask me, I'm going to have more nephrologists at ChenMed. No, I was like, I don't need nephrologist. I need good primary care, the non-nephrologist provider of care to deliver the right care.
Wow. Thank you so much, Dr. Kheda. I would like to take a quick 20-second commercial break, and then I'd like to talk a little bit more, especially for the students, people who are young doctors in training, about this concept of avoiding crashing into dialysis, as well as how you're helping primary care doctors minimize their exposure to like even nephrotoxins in addition to better management of things like diabetes and hypertension. So if we can take a quick 20-second break and then we'll come back.
ChenMed honors seniors with affordable, top-of-the-line care, and we're expanding. We're opening 25 new centers this year, including centers in 2 new cities, Houston and Detroit. Join us as we bring better healthcare to more seniors. Head to chenmed.com/physicians for more information.
And we're back. Just quick 20 seconds. So earlier, actually before the show, we were talking about training for nephrology and how there's a huge issue where residency spots for nephrology aren't being filled. Why do you think that is?
Nephrologist, I might be yelled at by some of my colleagues by calling ourselves the introverts of the medicine field. We as a specialty have so much going on, beautiful things to help patients, but we keep it to ourselves. We don't open up enough to educate and show all the great stuff we do regarding transplant, home dialysis, all this stuff. Like for a resident and a medical student who thinks about nephrology, they're thinking acid base and stuff that kind of at times can be like, do I need to know all that pathophysiology and a functioning of a nephron and a channels but there's so much more to nephrology that I think, could do better as a community of nephrology to share with these trainees. And I think that would probably open their eyes towards the broader opportunities in kidney care. I think we need to bring them under the umbrella, teach them what we do. And I think they'll open the doors for wanting to come and be one like us. One of the most sought after training or for a medical student in Medical College of Georgia, they wanted to do was a month of nephrology floor inpatient care. They loved it because there they could see the spectrum of this complex disease management and the stuff that they would have never learned otherwise. It was one of the famous, most sought after rotation in MCG when I was there. So we need to expose our trainees to nephrology more.
Yes. In addition to just recommending, the treatments for the CKD and like what you had mentioned earlier, I mean, there's so much exposure to nephrotoxins. I mean, even one medication can have such a profound impact over, the management of a patient with CKD. What has your experience been like being able to be so easily connected with physicians across the country within ChenMed?
Now, I think we have the drug dosing tools are so many out there nowadays. I think that I encourage utilizing those things, but they're always going to be the top 2 or 3 items, like NSAIDs, certain antibiotics we need to avoid, IV contrast we need to avoid, and actually overuse of ACE and ARB. Actually, that is a problem. I think we get trained that we need to put everybody, quote unquote, on a kidney protection therapy with ACE inhibitors and ARB. But the data underlying that is very clear that it is a great help only if you have proteinuria and significant proteinuria. But our mindset is let's put everybody on it. And what happens is you have an 80-year-old senior in our clinic who was doing okay and now gets put on ACE inhibitor just because we have to do it.
Yeah.
Don't have any proteinuria, and now they have hyperkalemia and all the stuff we need to sort out. So I think education around that is to less is good. Sometimes with medications, and proper dosing is better.
Yeah, sometimes you fall into this trap of following these guidelines, getting the clicks in, making sure that you have the patients on these medications, and you see that in many practices outside of the full risk model, where the primary care doctors don't even have 2 visits per patient per year. So they don't have time to build that relationship to be able to even educate them or even have a conversation.
You're right, and then we're fortunate at ChenMed that we see our patient every month. Once a month, we use that time opportunity to go over their care plan from visit to visit, and also avoid nephrology. A good nephrology care is kind of like a preventive care. You're preventing. You kind of needs to be wise enough to see what this medication or this intervention can do downstream for this patient, and not do it. That's the wisdom of doing, of a good nephrologist is at that point. And I think that's what's happening at ChenMed. I think we're developing these algorithms and technology based intervention, what we call clinical pathways as specialists, and it's really helping our clinicians. One is to do the right workup at the right time. If it's a proteinuria workup, renal cyst workup, hematuria workup, glomerulonephritis workup, all those is built into our technology platform. And the PCPs have access to it where they're making use of it, doing the workup timely. And then they're making intervention timely with treatment or consulting either through a virtual visit with me as a curbside consult, asking, hey, Dr. Kheda, I got this 2-gram proteinuria. What should I do? Should I send him for a kidney biopsy? And 9 out of 10 times, no, they don't need a kidney biopsy. We save a procedure, we save unnecessary medications. A lot of good things come out of it then, I think.
It's like what we see with what we've been seeing with geriatrics in hospitals across the country. Each geriatrician saving the hospital system and the patients millions of dollars. But if the goal is to generate revenue by billing, you're not helping the hospital by avoiding all of this crashing into dialysis.
Absolutely. The crash into dialysis is sad. We are come on the heels of Martin Luther King Day, and it's very rightful we are talking about kidney disease that is so impacted by disparity in care. African Americans have a highest crash rate into dialysis. That means they're starting their dialysis journey in the hospital, unknown, uneducated about kidney disease. We got African Americans having less of kidney transplants, less home dialysis. In our company, our 75% of our patients in our clinic that have high or high risk kidney disease in our dialysis are African Americans. 75%. Our design of our interventions are very kind of in tune to provide a better care for them. I don't know, Faisal, I think this is a platform I can also share that there's a big thing happening which will actually reset something in kidney space, which is a GFR. As you know, GFR is a lab value that measures and provides a risk stratification for a kidney disease patient, how bad their kidneys are. There's a the method we're using called MDRD traditionally is a 25, 30-year-old method, and it has flaw in there because of using race. There is effort across the country, and I think CMS will hopefully approve it quick when that gets finalized, that we're going to remove race from the GFR calculation. So we're going to be thinking kidney disease agnostic. We'll be a race agnostic kidney function or GFR measurement that the country will be using. But guess what we're doing at ChenMed? We are already doing that.
I was about to say we're probably already.
Yeah, we got with our technology. We have a wonderful technology side right in the company. We got together and we already have an unbiased GFR calculator in the background that we're using to stratify our patients. So we are already going race agnostic disease management at ChenMed across the company, taking care of the patient, the way they need to be taken care of.
So I want to walk on one more question from one of the listeners, and it sort of hits what you were talking about, Faisal, and thoughts on the Federal Trade Commission issued a proposed order imposing strict limits on future mergers. And I think, I'm sure they're talking about mergers of dialysis companies, but I mean, we also see this in health systems, and the more the merger occurs doesn't seem to help patients with regards to price or outcomes, but wonder what your thoughts are about that.
We have there has been a lot of conversation around that in the nephrology space because Dr. Dan, you would know that there are two companies in United States which we call our accounts for taking care of almost 80%, if not 90% of ESRD patients in the country. So it's kind of like some people will call it duopoly and oligopoly and all that. But there is that, and that impacts the care at times, has been noted. Like my example for kidney transplant, it was shown that patient who dialyzes at a for-profit dialysis clinic versus a not-for-profit, smaller, not these two, but other clinics, tend to have better referral rate for kidney transplant. So there are those kind of items that have come up when you have less competition.
Yeah, you just got to follow the money. I mean, it doesn't make sense. Why would they hurt their bottom line?
I know, right? I mean, it's a fee-for-service system, right, for them. Every treatment they come in, they get a certain amount of money, a bundle payment from CMS. Every dialysis treatment they get. So their goal as a business, rightfully, is to get as many patients as many times a month to do dialysis, irrespective. Sometimes you can make a case: do they even need it? Or we can argue about it. I mean, do everybody who's in the end of their life journey need 3 times a week dialysis? Do everybody who start dialysis has what we call residual kidney function? Do they need 3 times a week dialysis? Why do we always have to go from 0 to 60 on day one?
No, I mean, you bring up a very good point. And Faisel and I've talked about this many times. I mean, these are good people that are being forced to work in a system with the wrong incentives. And it doesn't mean that they're bad people doing that. They went into caring profession for the right reasons. And especially when you get into the for-profit and you have you have the business people running it. If you ask the CEO of a corporation, they'll say that there are ethical obligations to the shareholders. Well, I don't know. If I'm getting dialysis, I'd sort of like my dialysis provider's ethical obligation to be to me, not to their shareholder. But I'm sure that the people that have their retirement funds invested there would disagree with me. But it's I don't. I think you're right. We somehow need to change. Well, instead of paying for doing things, we need to pay for outcomes. And I don't know how we make that change. I used to think it could happen overnight. I'm a little bit skeptical about that now.
We are fortunately making baby steps, and credit to the CMMI initiatives around it. There's a kidney care choice and something called ETC model. A couple of models that are out there that are really forcing the hand of dialysis providers, nephrologists, the hospital systems, everybody involved in kidney care to go upstream. When I say upstream, means go upstream above dialysis to the kidney care space. Take care of your patients better there. Don't let them come to dialysis, and we'll give you incentive for doing that. It is already in play. Wish more and more people would sign up for it. A lot of it is voluntary model versus non-voluntary, then, as you would know. But I think there are good initiatives and reasoning behind it. Hopefully more people sign up, and we'll be in a better place soon.
Wow, Dr. Kheda, thank you so much for joining us tonight. This has been a great conversation.
Yeah, my pleasure, Faisal. I like the background. You did a wonderful job with the kidneys, with the stethoscope on that, checking the health of the kidney. I love it.
Well, that wasn't me. That was the producers of the show, Drew and Jess from
All
Split
right.
Prism. They are just amazing with their promotions and their designs. I love it.
Wonderful.
And to our audience, thank you so much for joining us this evening as well. What a great conversation, Dr. Dan.
Absolutely. I think this is so exciting now that we're starting to talk about the specialists that are interested in the value-based care model. I mean, there's enough work for all of us to do here.
That's right. Well, to our audience, for more information about tonight's topic and to explore career opportunities with ChenMed, please visit chenmed.com. We believe access to primary care is a right, not a privilege.